All right, welcome to Endoscopy Conference. I'm Tibora, for whoever doesn't know me, second year GI fellow. So I'm gonna start off with this case. It's a 38-year-old male. He has a past medical history of a Roux-en-Y. Initially presented at an outside hospital with dysuria and some rectal pain. He was treated for UTI and hemorrhoids. His CT at that time also showed proctocolitis, which was treated with antibiotics. He represented with ongoing symptoms. No further workup was done. He subsequently developed bright red blood per rectum at home with every bowel movement. He went about 10 to 20 bowel movements a day. He went to his primary care doctor who was unable to do a rectal exam because of severe pain, and he was sent to us. That's when we see him. He denies really any weight loss, any loss of appetite, no fevers or chills. He doesn't have a family history of cancer or IBD. He's afebrile in vitals and otherwise quite stable. I couldn't do a full rectal exam because of the severe pain that he had, but I did note a fluctuance in his right buttock. His hemoglobin, he was anemic with a normal MCV. He did have elevated ESR CRP to 72 and 121, and his creatinine was up as well, 1.39. We repeated a CT here that showed the rectosigmoid inflammation and this question of underlying malignancy, as well as hydronephrosis and wall thickening of the bladder. In order to further kind of look at these findings, we got an MR pelvis. It showed abnormal wall thickening of the rectum and anal region with both mucosa and serosa enhancement and surrounding phlegmonous changes. He had multiple surrounding small pockets in that region, and he also had a fistula from the 6 o'clock the anal verge into the medial right buttock. And then he had lots of fat planes between the abnormal rectum and the urinary bladder with abnormal wall thickening of the urinary bladder as well. So we decided to do an endoscopy. I actually couldn't even do a DRE. It was so tight. We ended up getting a pediatric gastroscope that we entered. This is about 20 centimeters in, and I'll show you what we found like before that. Here you see some congested erythematous, very boggy mucosa. And so this is more proximal to the 20 centimeters that I will show you in the next slide. There we go. So you'll see a lot of, necrotic tissue, really no normal interspersed mucosa at all. And that's for about 20 centimeters until we get to the anal verge. So the pathology actually came back to endoscopic biopsy, came back as rectal mucosa with erosions and acute inflammatory exudates, no malignancy seen. He went for surgical anal verge biopsy, and that shows squamous mucosa with Signet ring carcinoma. So I wanted to talk today a little bit about colorectal primary Signet ring cell carcinoma, which is what this was. I'm going to specifically focus on this article, the title of Outcomes of Surgical Treatment of Primary Signet Ring Carcinoma of the Colon and Rectum. And this is a literature review, a retrospective study with 22 cases. So just a little bit of background. Primary Signet ring carcinoma is most commonly actually found in the stomach as we know it, rarely in the breast, the pancreas, the gallbladder, the bladder. Also rarely found as a colorectal cancer, thought to be, most of the literature quotes around 1%, you see some around like 2.5% of the cases. The diagnosis is made when on pathology there's at least 50% of Signet ring cells. It carries a poor prognosis, often found in young adults, which we kind of spoke about during another case conference. They often present with late symptoms and are therefore diagnosed at a pretty advanced stage. It's sometimes referred to as cloniculonitis plasticus because of its diffuse infiltration of the intestine and a circular thickening of the bowel wall, which we usually mostly see in the stomach, but now it's kind of like a similar finding in the colon, though what we found didn't quite look like that. So this study was a retrospective study, as I said. The cases were collected between March 2007 and June 2013. There were a total of 842 cases of primary colorectal cancer, and only 22 of them had Signet ring cell carcinoma of the colon or the rectum. The results, so 54.5% were younger than 40. 59% was located in the rectum. Most of the patients had late-stage disease at the time of diagnosis, and greater than 90% of the patients had stage 3 and 4 disease. And the most common metastasis was the peritoneum, which our patient had as well. He had that hydronephrosis and had obstructive uropathy from the cancer. Curative resection with radical lymphatic dissection was achieved in about 50% of the cases, and palliative resection in the other 50%. And the mean survival time is actually based on that. So it was about 48.4 months for the patients who underwent curative resection, and only 19 months for the patients who underwent palliative resection. So our patient, in March, he underwent diverting descending loop colostomy. He has been undergoing treatment in April. Initially, when I checked, he was having good chemo response with stable tumor burden and downtrending markers. But in the last, he hasn't had chemo since September. He basically has been in and out of the hospital. He's currently hospitalized because his percutaneous nephrostomy tube was dislodged, and he was found to have a new pathologic lumbar spine compression fracture, as well as a right femoral DVT, and he's awaiting angioplasty and thrombectomy. So, you know, this cancer, it really carries a really poor prognosis, which is very unfortunate. And our guy initially seemed to be doing okay, but actually he's not really doing quite well, kind of corresponding to what, you know, I found in the literature regarding his prognosis.
Wow, that is an impressive case. I have 2 questions before we open it up to the audience. So one, are there any risk factors for this? You know, so for example, with anal cancer, it can be associated with high risk behavior, you know, HPV, that kind of thing. Are there any known risk factors for this, particularly in the colon rectum? And then second question, and I don't know if any of our pathologists are here, why is it that Signet ring presents with this linitis picture? I think it's a very important thing to point out is that it was a really markedly abnormal flexible sigmoidoscopy you guys did, but the biopsies, mucosal biopsies, didn't show the cancer. And we see this all the time in the stomach with usually like a distal gastric cancer causing a gastric outlet obstruction. Patient will get an EGD with biopsies, it'll come back without showing any malignancy. They'll get treated for PPI, come back, same thing. And then it's not until we do like an EUS and a biopsy, a needle biopsy of the wall, that we find the cancer. So is there something in particular about signet ring cancers in general that cause infiltration in the wall and make mucosal biopsy so difficult? And are there any clinical risk factors for these people?
So I'm going to answer the first question. I'm going to leave the second question to see if there's any pathologists who can answer that. But the first question, you know, I did give a case conference one time about colon cancer in young patients in general, and there didn't seem to be any risk factors. And in the studies that I looked at now, also not. They're often young patients, often without family history, not, you know, any genetic disorder related. I don't know if Dr. Itzkowitz knows a little bit more, but that was kind of what I found from my research.
Yeah, so whenever you see signet ring carcinoma in the colon, you have to think Lynch syndrome, because what signet ring cells are intracellular mucin. And with Lynch syndrome, probably half the time you see either intracellular mucin in the form of signet ring cells, but more often than that, you see extracellular mucin called colloid carcinoma. Whenever you see colloid carcinoma or signet ring cells, you have to think Lynch. They should have stained this cell block for the Lynch genes.
It was not consistent.
It was not, okay.
No. And also in the study that I looked at, there were a few studies, actually most percentage, like of these 22 patients, they were not associated with Lynch. Yeah.
Okay, so it's still possible. I mean, I would still offer this guy genetic testing if he's got any. It's not going to help him. He's got a terrible prognosis, but might help siblings or children if a rare gene might be encountered. The other thing to think about is with these signet rings, so signet ring cell carcinoma in the stomach is a very common variant, like Chris said, but in the colon, it's very rare, like you said, Sephora, maybe 1%. The thing also about these things is they get a trousseau syndrome. They get migratory thrombophlebitis from the mucin production of the tumor cells. And I've had a couple of patients die very prematurely from a pulmonary embolism, and he's already on his way to that with that DVT. So that's not unusual. Another thing, a board question, is that cancers in this region either arise from squamous mucosa or the columnar lining in that region. And there's a classification of cancers in this anatomic location called cloacogenic carcinoma. This is the cloaca region, and cloacogenic carcinomas can either be adenocarcinomas, which would have signet ring cells, or squamous carcinomas. Sometimes you even see a mixture of glandular and squamous morphology. It doesn't matter all that much, except that usually squamous cell carcinomas are more radiosensitive, so you would offer XRT, whereas with adenocarcinoma, XRT doesn't do very much. And this guy has metastatic disease, so the XRT would of course be palliative. So it's an interesting case. I would just encourage, it seems to me that the last few grand rounds, we haven't had pathologists on the line, I don't think. And for a case like this, we really should be showing the histology because we don't have pathology conference any longer. And if you just saw an H&E of this, you would really get a better understanding of the biology. So I think we should make a real effort in future grand rounds to show pathology slides.
I like that.
And they're more than happy to participate if we just ask them. So I can send a reminder out to them.
Yeah.
Any other thoughts or questions about this case? Really, I've never seen this before. Steve, do you have any insight into why these signet ring cancers often present in a linitis picture?
Well, it's interesting. In the stomach, they often have CDH1 mutations, which CDH1 is E-cadherin. And E-cadherin is a protein on the surface of epithelial cells that keeps epithelial cells joined together. And if you lack E-cadherin because of a mutation in that gene, the cells separate. And when you look at gastric cancers, signet ring cancers are notoriously, you see a cell here, a cell there, they're not cohesive, they don't form glands. And that's what signet ring cells do. They just sort of go off on their own and they spread laterally in the wall before they even create a mass that's visible on the mucosal surface. So they're really treacherous, especially in the stomach, as you said, Chris. You have to do multiple biopsies. You often have to, get into the wall of the bowel, of the stomach or the rectum. So the reason I think your biopsies were not diagnostic was because it was so necrotic. You probably, would have had to take 10 passes just to get some viable tissue.
Sipori, did you say the patient had a gastrectomy before?
He had a Roux Y.
So, was there a cancer in that specimen? Is this metastatic?
It was metastatic, but not thought to be to the stomach. He had it mostly to the peritoneum.
You could do, they could do special stainings. There's something called CDX2, which if it's positive, would mean that it's colonic in etiology rather than gastric.
Yeah, on pathology, it was considered primary colonic.
Primary colonic. Yeah, there are some special stains they can do for that. But it's a good thought, Brian.
They seem to have a worse prognosis, overall. So.
Okay. Sipora, that was fantastic. Thank you very much. Okay, I'm gonna turn it over to Lauren, I believe.
Morning, everyone. Let me share my screen here. Okay. Okay, can you all see my screen?
Mm-hmm.
Okay, so this is, let me move this. All right, so this is the second case for Endoscopy Conference. I'm Lauren, I'm one of the first years. So I'm going to present a continuation of the case that I presented last week, just because it's a pretty rare case and pretty interesting. So in case you missed it or have not been thinking about it all week, I'll just recap. So I had a 46-year-old female with uncomplicated small bowel Crohn's, not on treatment. coming in with a month of progressive dysphagia, no dynaphagia, as well as shortness of breath. Had pretty unremarkable vital signs and exam. Normal white count, baseline hemoglobin, and some elevated inflammatory markers. Had an outside contrasted CT chest that showed mild diffuse fat stranding in the mediastinum, concerning for tracheal and esophageal inflammation. And so last week I talked about upper GI manifestations of IBD and Crohn's and esophageal Crohn's disease, but this patient also had airway involvement so we scoped her, we did an EGD, but she also was seen by pulmonology and underwent a bronch. So I thought it would be interesting today to just mix it up and look at her bronch images and talk about airway involvement of Crohn's disease and ulcerative colitis. So these are pictures of her bronch. So picture number 1 shows the glottis, fairly normal appearing. There might be a little bit of edema at the area of epiglottic folds, but overall pretty okay looking. Pictures 2 through 4 showed evidence of diffuse tracheitis. So you can see that the trachea has a bit of a nodular texture to the mucosa, has some edema and some kind of linear streaking. Picture 5 shows NBI. You can see some hypervascularity of the trachea. Picture 6, you can actually appreciate pretty well that she's got some edema in her right middle lobe around the bronchus intermedius. And then 7 and 8 actually show dynamic airway collapse. So in picture 7, you'll see bronchomalacia, and picture 8, you'll see some tracheomalacia, which I thought was pretty interesting. She had some pretty significant airway disease on her bronchoscopy and some pretty mild insidious shortness of breath when she clinically presented. So those are pictures of her bronch. Just to remind you of the pathology, when we did her endoscopy and biopsy, we really didn't see anything too exciting, just some chronic active esophagitis, but her tracheal biopsies with pulm showed chronic and eosinophilic inflammation with small granulomas consistent with airway Crohn's disease. So she was managed with a prednisone taper and then tentatively planned for biologic therapy as an outpatient. So I'm going to talk just for a few minutes about respiratory manifestations of IBD, since this is pretty rare. This may be a little basic for this audience, but I didn't know much about it, so I read this review article, and I'll summarize the key points. So as for the background, airway involvement in IBD is pretty rare. This paper was a few years old, but at that point cited less than 1% with only 24 cases in the literature. I thought it was interesting that oftentimes we think of extraintestinal manifestations of IBD more as like a Crohn's phenomenon, but airway involvement is actually far more common in ulcerative colitis. There are a couple of different subgroups. So by and large, the large airway disease is the most common, and we'll see that in about 40 to 60% of patients with airway involvement in IBD, and most commonly presents with bronchiectasis and chronic bronchitis. Kind of next would be interstitial involvement, and that is most commonly seen as granulomatous bronchiolitis. And then kind of the next bullet points are really a mixed bag and are much more rare. So you've got serositis, vasculitis, necrobiotic nodules, which are actually sterile nodules that you can see in the lungs, which can cavitate and sort of look like tuberculosis. Drug-induced lung disease from any of the biologics, which is a whole nother talk in and of itself, and then enteropulmonary fistulas. This picture is a little fuzzy, I apologize, but I thought it was a pretty good schematic. So typically, the pathogenesis, you start with intestinal inflammation. I'll talk more about this on the next slide, but typically you have known IBD for a long time before you develop airway involvement. And then you add on to that potential risk factors. So this paper talked about a whole kind of host of genetic and environmental risk factors like smoking, bacterial translocation. They talked about dysregulation of alpha-1 antitrypsin. And then I thought it was interesting, they did mention, I think we had just talked about too in the last presentation, embryonic origin. So mucosal associated lymphatic tissue, GALT in the lungs and GALT in the gut, both come from the same kind of foregut area embryologically. So there's some connection there. So the intestinal inflammation plus some risk or environmental or genetic factor will lead to subclinical disease, small or large airway disease, which I'll talk about next. So the clinical presentation, most patients are actually asymptomatic, which I thought was interesting, and airway involvement is detected incidentally either on high resolution CT or PFTs. This paper said that about 85% of patients will develop airway disease months to decades after their initial IBD presentation. Can often be an asthma mimic, so pretty mild symptoms in a lot of cases, or as I said, asymptomatic, so cough, sputum production, wheezing, or just breathlessness. In rare cases, when patients have tracheomalacia or bronchiomalacia, you might see stridor or hoarseness. And then symptoms are often independent of IBD activity, and large airway disease in particular is not responsive in parallel to surgical management and can actually get worse after these patients have any sort of resection. The diagnosis can be made in several ways. So this review talked about if you see a patient in clinic, kind of the lowest hanging fruits and least invasive methods of diagnosis are high resolution CT or PFTs. And I thought it was interesting that about half of active IBD patients in one of the studies they cited were abnormal, even in patients who were asymptomatic. And they also mentioned that 61% of asymptomatic Crohn's patients in one study had bronchoalveolar lavage features of lymphocytic alveolitis. So again, airway involvement is probably much more common than we realize and can be seen in asymptomatic patients. And then of course you can do biopsy to get tissue, wedge, transbronchial biopsy like our patient had, or open resection for whatever reason, and find it incidentally. So on the differential of airway involvement of IBD, you have pretty much any other inflammatory airway disease that can cause bronchiectasis, nodules, cavitation. So sarcoidosis, amyloid, GPA, tuberculosis, and then asthma, COPD, sarcoid, and alpha-1 antitrypsin can actually coincide with IBD, although I'm not totally clear on whether or not these are actually extraintestinal manifestations or if they're truly separate clinical entities that are coinciding. So for the treatment, the standard treatment seems to be high-dose steroids, so 60 to 80 milligrams of IV methylpred daily. And in refractory cases, you may need to have these patients go for rigid bronch with dilation, lasering, or stenting. So the overall takeaways here, so in IBD patients with respiratory symptoms, attribute them to their IBD first, as this is much more common than I would have at least thought, as opposed to telling them that, saying that they just have now asthma as well. You can easily evaluate patients in clinic with PFTs and high resolution CT. IBD should always be in the differential of bronchiectasis and bronchiolitis. Asthma, COPD, sarcoid, alpha-1, and IBD may overlap. And then airway disease may not follow the intestinal course. All right, any questions?
So when I first got to Mount Sinai, which is about 10 years ago, I was asked to see somebody for upper GI Crohn's disease, but also had pulmonary Crohn's disease. And I said, come on, you guys are making things up. There's no such thing as Crohn's of the airway. But sure enough, this person did have it. So I was blown away when I was exposed to that diagnosis. Questions for you. Are there any, similar to the first case, are there any specific subtypes of IBD, like any risk factors or exposures? Like, is smoking a risk factor for this? Yeah, I guess that's my main question out of curiosity.
Yeah, the review listed smoking definitely as one of them, and then kind of like genetic predispositions like dysregulation of alpha-1 antitrypsin, but it seems very unclear. It seems like you have to have the initial substrate of the bowel disease, and then you have some sort of genetic predisposition or environmental inciting factor that leads to the airway disease decades later, usually months to decades later.
But the truth is that this is overt pulmonary Crohn's is so rare, as overt as this patient, that there aren't any really good big cohorts. So it's really hard to identify true risk factors. The numbers of patients that you see with this degree of pulmonary involvement with Crohn's disease is very, very small. It, no doubt, as you said, it's much more common than we know, but it tends to be more, softer presentations, if you will. But I think there have been a handful of cohorts that have looked at a large number of Crohn's patients who don't have obvious pulmonary symptoms and actually find a fair bit of high percentage with pulmonary manifestations, altered PFTs and the like. And the reasoning is that there's common leukocyte trafficking between the gut and the lung, that the leukocytes actually will traffic to the gut and may have the same targeted effect in the lung. Or so.
Do any of the patients present with pulmonary Crohn's before with GI Crohn's symptoms?
The paper that I read said that was extremely rare. I think it was less than maybe 10% of cases would have pulmonary symptoms first, but I don't know if anyone else can comment.
It's extraordinarily rare. You know, again, I've in 26 some odd years of seeing IBD patients, people with overt pulmonary Crohn's to this degree, I have had maybe 3, including one who was case presentation at MGH in the New England Journal, EPC, who had laryngeal Crohn's, who later was diagnosed with ileal Crohn's. That was really rare.
Any other thoughts or comments?
I just had a quick question. Lauren, you mentioned that steroids were one of the treatment options. Why doesn't Remicade or something else systemic work here?
Oh, that's a good question. I feel like just based on the path or the course of the airway disease, it doesn't seem to follow the bowel disease at all. So I don't know. I actually don't know. If anyone could comment on that, that would be helpful. But it seems like the lung disease does not clinically follow the bowel disease, and therefore I just probably doesn't respond to treatment as well. Does anyone know?
But like in terms of Vado, you could argue that Vado stops trafficking if it does to the gut, so therefore would be more selective, but Remicade should really be more systemic, no?
I really think it's not so clear that these things do or do not work. Again, the numbers of patients that you see in the literature are so small.
Okay, thanks.
You really can't draw firm conclusions about it.
And Lauren, you mentioned something about there was one study, you know, where they, I guess, kind of did PFTs in, I assume, just some IBD cohort. What did that show? Was there, in asymptomatic patients, were there abnormalities that led to, you know, potential underlying diagnosis?
Yeah, so they said, and I didn't dive into this paper on its own, but they said about 50% of patients, and I think they looked at all comers, symptomatic and asymptomatic. No, sorry, they looked at only asymptomatic, had some sort of PFT abnormality. But as far as, was it like the DLCO was off or the FEV, or I don't know, you know, specifically what they found, but something was abnormal in about half of patients. So
It's interesting. It's definitely interesting. So, all right. Any last comments? Very cool case. Thank you so much.
thanks.
Okay, I see Nick is online. Move over to advanced endoscopy.
All right, thank you. And today I'm going to present a case entitled "My Stomach is in Knots." Got to keep the interesting titles. All right, so we had a 50-year-old male, history of fascioscapulohumeral muscular dystrophy, which is a mouthful, but basically he had kyphoscoliosis and recurrent gastric volvulus. And it was an unusual presentation. We normally think of gastric volvulus as sort of this catastrophic presentation with pain and potentially ischemia. But he just presented with this feeling that his stomach volvulized just intermittently throughout the day. If he rotated to the wrong side, his stomach would just flip, and he manually derotated it back. His stomach was like scaphoid, and he could essentially feel his stomach and rotate it back. So it's very unusual, but it was very uncomfortable for him because he basically continuously had this sensation that his stomach was rotating around in his abdomen. And so we were called because he was not a good surgical candidate due to the muscular dystrophy. They were afraid of anesthetizing him, giving him general anesthesia, and also because of the kyphoscoliosis, he had very abnormal anatomy. And we were consulted for an attempt at endoscopic gastropexy. And this has been done before with either a peg, which is a single point of fixation, or 2 pegs with the goal of having 2 points of fixation to prevent the peg being sort of another sort of nidus for rotation. And so we did a little modification of the 2 peg technique with the goal of having 1 peg and then 1 transabdominal suture, which I will describe. So here's the endoscopy. And we had already placed the peg. So during this procedure, we placed the peg. I didn't show that part because it's not really anything novel. Then a site was located about 5 centimeters away from the peg for the second fixation point. And we used, this is a 14 gauge angiocath from the skin into the stomach, very similar to placing a peg with the trocar. Through this, we placed a spy bite forceps, which is used in cholangioscopy to biopsy the bile duct, but it's small enough to fit through this angiocath. And we passed a suture. So the suture now goes from the skin into the stomach. And then here we grab the suture just to hold it. And we place a second angiocath immediately adjacent to the first and place the biopsy forceps through that. And then we will grasp the suture and pull that back out through the skin.
What kind of suture did you use?
So I will admit, I don't know anything about sutures. So we called the surgeons and we asked them, what would you use if you were doing a gastropexy, basically, because we're trying to simulate essentially a surgical gastropexy. And they said, anything will work. You just need it to hold long enough and be strong enough to create some fibrosis. So this is a 2O vicryl, which is an absorbable suture, and it's pretty thick. We actually end up placing 2, as you can see here. So this is also a 2O silk. And the surgeon said that I think the silk would probably cause more of an inflammatory reaction, but we just doubled up and they thought that was a reasonable approach. So we pulled both through, and essentially now we have these sutures coming out from the skin into the stomach lumen and then out through the skin again. And we pull the angiocath out, and then we're just left with the suture. Pretty simple. So the suture was tied just like normal outside the body, and then we'll get a look at the final result here inside. And here's the 2 sites. So the peg, and then a few centimeters away, the suture site. And here's the external result. As you can see, pretty simplistic, nothing too crazy. But amazingly, I thought maybe we would need some follow-up to see if he volvulizes again, but because he volvulized so frequently, he just felt immediately better. He was one of the happiest, most satisfied patients I think we've ever had. He just woke up and just felt amazing. And in he was having multiple episodes a day. 2 weeks later, nothing, totally fine. So it's a very satisfying result for him with a pretty minimally invasive procedure. So we can talk a little bit about gastric volvulus, since there's not much to talk about endoscopic transabdominal suturing, because I didn't find any cases of endoscopic transabdominal suturing in literature. But gastric volvulus has a couple different causes. This patient had more of a primary gastric volvulus due to kyphoscoliosis. There's tension on the ligaments that hold the stomach, and they loosen and allow the stomach to twist. Other cases, more commonly, are secondary, either in older people to a paraesophageal hernia using as a lead point, or in younger, like pediatric cases, a diaphragmatic hernia, or phrenic nerve paralysis, another cited cause. The presentation, and this is actually sort of a board's question, is pain, vomiting, and then inability to pass an NG tube. That's like the key word in the board's question. Since I just took the boards, I'm very aware of these things. And they can present with peritonitis, which implies that there's an ischemic component after the volvulus. There can also be patients who have chronic volvulus with more vague symptoms of abdominal pain, vomiting, dysphagia, early satiety. This is the classic radiographic presentation. On the left, you can see the gastric bubble is in the chest, and there's an NG tube actually coiled inside this stomach, but it's all in the chest. On the right, you can also see actually a pretty cool picture of an organoaxial volvulus, which is one of the 2 ways it can flip. I didn't go too much into detail. This is more like surgical details about the 2 ways. This is the most common way. And management is resuscitation, decompression, which can be an NG if you can pass it. If you can't, endoscopy is an option because it's more rigid. And you can also assess for ischemia during endoscopy. Indications for emergent surgery would be if you're unable to decompress the stomach, if there's evidence of perforation, ischemia, sepsis, shock. And then more definitive management is traditionally surgical. In primary gastric volvulus, you have to derotate the stomach and then perform gastropexy to prevent it from rotating back. Secondary gastric volvulus, you don't necessarily have to perform gastropexy because the primary problem is the anatomic defect that led to the volvulus in the first place. And so if you repair, say, the paraesophageal hernia, then that prevents the volvulus from recurring. In poor surgical candidates, endoscopic management has been described as here. And there is a way of endoscopic detorsion that you can see on the right of the screen. This was a case series of 8 patients, and 7 of them, they were able to detorse. I've never attempted this maneuver, but what you can theoretically do is create an alpha loop in the stomach, go through the defect where it's twisted, and then as you reduce the loop, it reduces the volvulus. Maybe it would work. You kind of have to guess which way it's going to go. In some cases, they went one way and it didn't work. They went the other way and it worked. But theoretically, you could do that. I don't know if anyone's ever had any experience with that. That's it.
That is tremendous. So question,
One.
Knowing how well the suturing part of this worked, did the patient actually need the peg tube for nutrition? Like in theory, if you had to do this again, could you have just done 2 sites of suturing?
So I had this thought, since it was sort of an experimental, sort of newer treatment, we were hesitant to try something completely novel with 2 suturing sites only in this case. And because of his muscular dystrophy, it's progressing. He actually probably won't need the peg in this case. I think if the suture does hold up, I think potentially you could just do 2 suturing sites if the patient didn't need a peg.
Just so everybody understands, we used to do this for cecal volvuluses, and we abandoned it because the recurrence rate was so high. I'm not sure whether that's going to be the case here or not, but after 2 weeks, I would say great, but I'd like to see the guy 6 months from now.
Sure. Yeah, we'll have some longer term follow-up.
Well, along those lines, what potential? So, I mean, this looks amazing. What would be the potential reason for failure here? Why would a surgical approach be, why is this not better than a surgical approach? What could you anticipate happening that this could?
What happens is if I did 2 pegs, okay, I would feel much more comfortable, but you have such a small contact point that even if it's a permanent suture, it can easily, as the stomach gets bigger, pull out over time, or you can develop an adhesion between the anterior abdominal wall and this area, and it can respin again. And that's what happened. We've done cecopexies that have been successful for long periods of time, but we've also seen them recur quite frequently. Once again, I think it's a great idea to do the peg. I think that's probably the greater issue here. The peg probably will hold things in place. But if this were not to work, I would consider doing 2 pegs. It's a much greater fixation than just a simple, easy suture. And I know it looks like it's a big suture to you, but 2.0 is not very big. and I would certainly suggest that your suture go further apart. It looks like it's pretty close. So what you want to do is do it as far apart as you can. Okay, that gives more contact to the anterior abdominal wall, the posterior abdominal wall to the stomach, and hopefully that will give more fibrosis and fix it so that it doesn't happen. Great case.
Part of the complicating factor in this guy's case, he was severely underweight with a scaphoid abdomen, which is why we definitely wanted to get at least 1 peg in from a nutritional standpoint, but his abdomen was a mess. We tried to go as far apart as possible safely. And we were a little bit concerned in when we tried to go a little bit more laterally out that we were in the region of the liver, and then on the left side of the abdomen, we just saw these very massive sort of vessels literally along his entire abdominal wall that made us a little bit nervous. We did entertain the dual peg route, but the patient was not keen on having 2 pegs. And we had a conversation with him and his primary GI doctors, who are Peter Rubin and Steve Namagon, about dual peg versus, this sort of transabdominal suturing, which it has been described for closure of chronic gastric cutaneous fistulas, which is where we sort of got the idea from. Limited efficacy in it, but it was sort of an out-of-the-box approach that we felt we could potentially offer this patient with the backup of putting in another peg if it didn't work. So he's been feeling good. We'll keep our fingers crossed. I wasn't as, when he woke up saying, "Oh my God, I feel great," I was a little skeptical, but we'll see what happens moving forward.
Great case. Good job.
Yeah, that's really cool.
Nick, can I ask a question, Nick? That was amazing.
Sure.
How did you pick those 2 points? Like, did you look at the scans to see where you thought it was twisting on the axis and pick the points accordingly? That seems really hard.
As Nikhil described, we were honestly just limited in what sites we had. We wanted them as far apart as we could, but his abdomen was very abnormal with the scoliosis and the malnutrition element there. We just picked whatever window we thought was viable, similar to when you place a peg.
Very cool. Very cool. All right. In the last few minutes, I have a quick case I'd like to share. So this is a 71-year-old man. I don't have slides yet, but I'll go to the video in a second. This is a 71-year-old man with a history of pancreas cancer who had an uncovered metal biliary stent placed about a year and a half prior to admission, who came into Mount Sinai with cholangitis and polymicrobial bacteremia. He had E. coli and Klebsiella. And based on imaging, he had an occluded biliary stent. So our plan was to do an ERCP. And when we got down there, we saw that his medial duodenal wall was necrotic and filled with debris. And we can actually see the lateral wall of the metal stent through this big defect. It was basically just tumor necrosis. We were able to see the metal biliary stent running through this cavity. So this was our approach to, and so the thought was that not only was his metal biliary stent occluding, but this cavity was just getting seeded and chronically infected and basically a big abscess cavity. So this was our approach to managing this. Everyone see my video here?
Yes.
Okay. So what you see here is the duodenal lumen. This is the medial duodenal wall, and here you see this big necrotic cavity, and that is the shaft of the uncovered biliary stent. The papilla would be down here, and this would be running cephalad this way. But when we did the ERCP and we injected contrast, because this is an uncovered stent, you see the contrast just extravasate through these holes and basically seed this cavity. So a very easy way to fix that problem was to place a fully covered metal stent through the uncovered metal stent, basically sealing off those side holes. But because we assumed that while this patient, had a slight duodenal obstruction, so the thought was that as he continues to eat, food is going to get held up in the duodenum and will continue to, sit into this cavity. So we had the thought of performing an endoscopic gastrojejunostomy so that food and luminal contents would be preferentially diverted away from the duodenum and through this bypass that we created. So here we filled up the jejunum with fluid, and we are going to place a lumen-opposing metal stent to create an anastomosis. So this is the contrast-filled bowel. Here's our EUS scope. And in a moment, we're using a electrocautery-enhanced lumen-opposing metal stent. We're going to puncture through the stomach wall into this jejunum. We deploy the internal flange of the lumen-opposing stent within the jejunum. And then you'll see in a second, we're going to deploy the intragastric flange of the stent. And what you're going to see is a big gush of blue fluid, which is methylene blue that we had instilled in the jejunum. This is confirming our location. So here's our gastrojejunostomy. Here's our gastrojejunostomy going into one of these fluid-filled loops. And then just to facilitate, openings, we dilated it, and there's the jejunum. So he did great. He was actually able to get out of the hospital, and he was able to actually not require admission or anything for several months. He was able to eat without any problem, no recurrent fevers or anything along those lines. And Unfortunately, now his cancer has progressed and he's in hospice. But you know, this was approximately 6 months ago or so. So we were able to keep him out of the hospital and allow him to maintain oral nutrition and, you know, avoid any further episodes of bacteremia and cholangitis. And that is my case. So with that, that is the conclusion of this morning's Jerry Waye conference.